Welcome to this explainer. Think about how many times you've swallowed today without even giving it a second thought. You take a sip of coffee, you chew a bite of breakfast, and down it goes. Simple, right? But beneath that seemingly mundane everyday action is actually a high-stakes biological thriller. Today, we're unpacking the incredible hidden mechanics of swallowing. We're going to dive into some expert medical insights to discover why, when it comes to the human body, airway protection is absolutely the ultimate priority. All right, let's dive right into this ticking clock. From start to finish, the most critical part of a swallow happens in exactly 1 to 1.5 seconds. That's it. In that incredibly brief window, your body has to perfectly choreograph a super complex sequence of muscle movements. And the singular, critical goal here? To ensure that food and liquid travel safely down into your stomach and absolutely do not enter your lungs. It's a high-speed, split-second maneuver that we completely take for granted. Well, until something goes wrong. So, what exactly is going on during that 1-second dance? Let's take a look at the physiology of swallowing. Swallowing is basically divided into 3 main acts. Step 1 is the oral phase. This is the part you control, chewing your food, mixing it with saliva, and using your tongue to push it backward. Skipping to step 3, you have the esophageal phase, which is just the slow transit down to the stomach. But right there in the middle, step 2, the pharyngeal phase, is where the real danger and honestly the real biological magic happens. The second the food crosses the back of your mouth, an involuntary reflex takes over. You are literally no longer in conscious control. Now, the crucial thing to understand here is how the body anchors its priorities during this involuntary phase. Because airway protection matters first, the body deploys this incredibly synchronized sequence of valving defense mechanisms. First, swallowing apnea kicks in. Your breathing literally stops for a brief moment, even if you don't realize it's happening. Then, the base of your tongue retracts, anchoring the whole movement. Next, the epiglottis folds down, acting exactly like a protective lid over your voice box. And finally, the vocal cords tightly contract to create this final impermeable seal. It's an absolute fortress built in milliseconds. And this brilliantly illustrates just how little room for error there is in our anatomy. Right above the esophagus, we have 2 small pockets called the pyriform sinuses. Think of them as tiny waiting rooms for your food. Each sinus has a capacity of exactly 15 milliliters. To put that into perspective, that's literally just a single tablespoon. Think about that. If the swallowing mechanism doesn't trigger perfectly to open the pathway below, it only takes that tiny amount of fluid to overflow those sinuses and spill straight into your unprotected airway. But what actually happens when this perfect split-second choreography fails? Let's move on to oropharyngeal dysphagia, or what happens when swallowing goes wrong. For patients who are recovering from strokes or battling neurodegenerative diseases, dysphagia becomes incredibly dangerous. Look, if a healthy person gets water down the wrong pipe, what doctors call penetration, they immediately eject it. We've all been there, right? A forceful cough reflex violently clears the airway. But many of these patients experience something called silent aspiration. Because their sensory nerves are impaired, food or liquid enters the airway, slips right past the vocal cords, and the patient doesn't even cough. Their airway is completely undefended, and they are aspirating directly into their lungs, completely silently. It is terrifying. Another specific structural failure is premature spillage. Imagine the tongue and oral muscles are just too weak to hold the food or liquid in place while chewing. The material prematurely drops down into the pharynx before that critical involuntary swallow reflex has even triggered. The airway hasn't had the chance to deploy its glottis or close its vocal cords yet, which leaves the respiratory system wide open to whatever is slipping down. To combat these invisible threats, specialists have to rely on some incredible diagnostic detective work. Let's look at FEES, which is a way of evaluating swallowing in real time. During a FEES exam, doctors pass a tiny flexible camera through the patient's nose to watch the throat in real time. And when they do, they are specifically looking for the white out sign. Now, you might think a camera blacking out is a technical glitch, right? But actually, when doctors watch a healthy swallow and the screen suddenly goes completely white for a split second, that brief visual blackout is exactly what they want to see. It proves that the larynx is successfully elevating upward and forward, essentially squeezing right against the tip of the camera and pulling the airways safely out of the path of the food. If there's no whiteout, it means the airway isn't pulling itself to safety. To standardize the threat level during this procedure, doctors use the penetration aspiration scale. Basically, they give patients some blue-dyed water or food and literally just watch where it goes. Scores up to a 4 mean the liquid might enter the top of the airway, but it stays above the vocal cords and gets successfully ejected. That's still considered a safe swallow, but scores of 5 and above, that is the severe danger zone. This is where the material actively passes below the vocal cords and into the trachea, which poses a massive, life-threatening risk for aspiration pneumonia. But here's the thing. The FEES detective is looking for clues long before the patient even takes a sip of that blue water. They meticulously test the anatomy first. They'll ask the patient to say E to check for vocal cord immobility. They have them say CAW to spot an incomplete soft palate closure. They're scanning for secretion stagnation, which is pooling saliva in those tiny pyriform sinuses we talked about earlier. And crucially, they physically touch the tissues with the camera to test for a lack of sensation. Think about it. If the patient can't feel the camera touching them, they certainly aren't going to feel food entering their airway. Okay, so we've covered the diagnosis. Let's move into testing, treatment, and the path to recovery. To figure out exactly what a patient can safely eat, medical teams use the IDDSI, the International Dysphagia Diet Standardization Initiative. They systematically test the swallow step by step. They might start at level 0, thin water. Now, water moves incredibly fast and is notoriously difficult for weakened muscles to control. So if that causes aspiration, they move up to level 4, a thicker puree. Sure, it might not be the most appetizing texture in the world, but it moves slower, it's way easier to manage, and most importantly, it guarantees airway protection. They'll just keep testing all the way up to level 7, which is regular foods like a cracker, carefully finding a diet that works for that specific patient. And here is where FEES truly shines as a rehabilitation tool. It's not just for diagnosis. It provides immediate video-assisted biofeedback directly to the patient. So if a patient is aspirating, the therapist might instruct them to try a chin tuck maneuver, or maybe a breath-holding supraglottic swallow. The patient can watch the monitor in real time, instantly seeing how tucking their chin physically changes their internal anatomy to successfully protect their airway. It makes the invisible visible. It completely empowers the patient to correct their own swallow. However, the path to recovery has some really surprising roadblocks. You might assume that a nasal feeding tube, an NG tube, is the perfect temporary fix for nutrition, but leaving an NG tube in for too long can actually cause its own serious problems. As our sources note, the physical tube acts like a wedge, keeping the upper esophageal sphincter propped open all the time. This not only increases the risk of stomach acid refluxing back up into a vulnerable airway, but the physical presence of the tube can actually hinder the very swallowing therapy that's meant to help the patient in the first place. And this beautifully illustrates why gastroenterologists and ENT specialists frequently collaborate to pivot to a PEG tube. For patients who just aren't recovering quickly, or those with progressive neurodegenerative diseases, placing a PEG tube directly into the stomach is a real game changer. It completely bypasses the throat. This removes that interfering nasal tube, ensures the patient gets optimal nutrition to build their physical strength, and above all, fiercely prioritizes respiratory health by keeping the airway completely clear of food hazards. Because, as we've seen time and time again, airway protection matters first. Which brings us to the horizon of this entire medical field. We're looking at a rapidly aging population globally, and that is directly driving a massive rise in strokes and neurodegenerative dysphagia. The sheer volume of patients losing their ability to protect their own airways is, quite frankly, staggering. So the crucial question we have to leave you with today is this: how will modern medicine scale this highly specialized, life-saving swallowing rehabilitation to meet this massive growing burden? It's a high-stakes challenge that absolutely demands our attention. Thank you so much for joining me on this explainer. Keep learning, and as always, stay curious.